Hello and welcome to Nursing 325, a lecture on elimination. In this lesson, we'll review medications that affect elimination, including diuretics, laxatives, anti-diarrheas, and medications used for IBS and inflammatory bowel disease. As we go through each class, focus on the mechanism of action, key adverse effects, contraindications, and important nursing considerations. Our first part of elimination is diuretics. What are diuretics? Diuretics increase urinary output by acting on different parts of the nephron. They are commonly used to manage hypertension, edema, and heart failure. Because they alter fluid and electrolyte balance, they need to be monitored very closely. There are three types of diuretics we're going to be covering. The first one is the thiazide diuretics, which is a hypochlorothiazide. This works in blocking sodium, water, and chloride reabsorption, thus increasing urinary output and potassium excretion. These medications require adequate kidney function to be effective. Some key adverse effects are hypokalemia, hyperglycemia, especially in patients with diabetes, and hyperuricemia, which is important for patients with gout. Nurses should monitor blood pressure, electrolytes, and blood sugar, and this should be administered orally, usually in the morning, with food to reduce GI upset. Second diuretic is a loop diuretic, or Lasix. It acts on the loop of Henle, and it's considered a high-potency diuretic. It significantly increases urinary output and potassium loss. Major concerns of this is including dehydration, hypotension, electrolyte imbalances, and ototoxicity, especially if it's given too rapidly in an IV push. IV Lasix should be administered slowly to reduce the risk of hearing damage, and nurses should assess blood pressure, fluid status, fluid and electrolyte imbalances, and potassium levels closely. It's best to give this in the morning with food, or if you're giving it in IV form in the morning, because if you think about this, if it's increasing urinary output quite a bit, you don't want to be giving this to your patients at night where they're going to have to get up quite frequently to use the restroom. And the third diuretic is the potassium-sparing diuretic, or spironolactone, which blocks the aldosterone in the distal nephrons. It results in sodium excretion and conserving potassium. While this is the weaker of the diuretics, it's very useful in preventing hypokalemia. However, hyperkalemia is still a significant risk. We can't rule it out. But because this drug in particular has such hormonal effects, patients may experience some changes, such as men with impotence or females in their menstrual cycle changes. So therefore, this drug is huge on being avoided in pregnancies. And also, because of the hyperkalemia effect, we also don't give it to patients in renal failure. Now, remember, as nurses, we still need to monitor blood pressure, adverse reactions, and this one is that you give it whole, you do not crush it, and you give it in the morning with food to help with absorption. This slide's just a quick compare and contrast of the three diuretics side by side to show you exactly where the site of action is taking place, the mechanism of action. Most of them, as you can tell, are all blocking sodium or chloride in water, which increases the urine, or aldosterone. And then it's got the therapeutic effects such as diuresis or decreasing blood pressure or preload of the heart. We also are looking at the strengths. You can see the strongest is still the Lasix compared to the weaker ones. And most of the side effects are very similar, so that's why we put them kind of next to each other. But there are some that have more risks than others, and we put that on here so you can see the hormonal risks versus the ototoxicity versus electrolytes. And then the biggest thing about some of these is the contraindications. The thiazine, I forgot to say on the other slides, is if you are allergic to sulfa, this is not a drug you can take. So you have to remember that to always check allergies, because that's important. And the other thing about this is patient education. We should always be checking our blood pressure before we give it. We're always checking your fluid and electrolytes, our eyes and nose. We're going to be giving it in the morning because if it's a diuretic and you want to have them void and pee, this is a drug you don't want to give in the evenings. So this is it. And the last one with the potassium sparing, we have to be careful about avoiding things that already have potassium in them, as well as salt substitutes that will just increase our potassium levels. That is different than what we would do for the other two with the thiazine and the Lasix, because if they're losing a lot of potassium, we actually will probably include that in their diet. Next up is looking at drugs for constipation, or laxatives to some extent. These are to treat constipation. It's used different mechanisms, which could be increasing the stool bulk, a stool softener, a stimulating the peristalsis, and then we've also got where it can draw water into the bowel to help. Proper education for our patients is critical to prevent any misuse of this, because of the fact that this can be abused, and this is not something that should be long-term. It should be very short-term fix. We also need to double check and monitor hydration status, dehydration status, fluid and electrolyte disturbances as well. The key here is always before meds is to check fiber, fluid, and activity. So put fiber in the diet, drink lots of water, and walk and do some activity to stimulate the bowels. The first of the laxative, which is going to be a bulk laxative, is psyllium or Metamucil. You've probably heard of that one before. It is a bulk forming laxative that absorbs water and forming a gel that softens the stool and stimulates the gut to produce a bowel movement. It typically reduces and produces some type of results of a stool within 1 to 3 days. The key here is it needs to be taken with a full glass of water or juice, at least 8 ounces of that, to prevent esophageal or intestinal obstruction. It's very important that we teach that to our patients. In addition to that, we need to separate this medication from any other medications that are going to be given by 1 to 2 hours. The biggest side effects that you're going to see on a lot of these constipation reducing drugs is cramping. And then remember, too much of a good thing of any drug goes the opposite direction. So yes, you have constipation, but if we give you too much, you're going to have diarrhea. So remember that. So one of the side effects can be diarrhea, which means we shouldn't be using that much. In addition to that, we have to also teach our patients and ask them if they're having any difficulty swallowing, chest pain, absence of bowel movements, or diarrhea. And then remember, still the key about this is a short-term fix. So we're still going to give them hydration, 2 to 3 liters of water a day, increase fiber in the diet, and definitely some type of exercise to stimulate the gut movement. This is just a fun card that we had students do to try to help remember certain drugs. So as you can see, psyllium, Metamucil, we were figuring out how does it work. It's some of the stuff I just talked about on the other slide, but sometimes if you're more of a picture person versus a word person, and it reminds you, soft stool in 1 to 3 days, that's kind of what this is saying here. Need to drink lots of water or juice to go with it, at least 8 ounces so that you can produce it. But what are some side effects? You got nausea, vomiting, you've got diarrhea or cramping on here. So this is just a fun way, you'll see in a couple other slides, to possibly learn the drug and not just memorize it. Our next medication is a surfactant laxative, or what we would consider Colace. It allows water to enter the stool, making it easier to pass. It's what we call a stool softener. It's commonly used to prevent constipation and fecal impaction. It should be taken with a full glass of water and discontinued if diarrhea develops. The key thing is it takes 1 to 3 days. It does cause, again, bowel cramping, diarrhea if it's too good, and do not administer it within 2 hours of any other type of laxatives. Again, the biggest education on this, full glass of water, and teach the patients that they need to stop it once results are occurring, such as the stool is soft enough to pass. Another drug we use for constipation is a stimulant laxatives, or Senna or Senokot, that we've used before. And of course, as you can tell, it is often used to increase intestinal motility, and it's used for opioid-induced constipation or bowel preps for some people. It is comes orally and it forms, typically works within about 6 to 12 hours, so it's pretty fast compared to the other ones that were 1 to 3 days. While they can be given orally, they can also be given suppository, and as you notice, it's key to have this given at night so that it can work and take effect. If it is given a suppository, you're going to get it pretty fast within 15 to 60 minutes. So keep that in mind as well too. Now, long-term use of this can lead to dependence. So we have to make sure that we, again, teach our patients that this is a short-term thing, not a long-term thing. So we usually need to be cautious with this. And the biggest thing here is that once some patients, if they become too dependent on it, they're unable to have a bowel movement on their own without it, and they'll require higher and higher doses as the time goes on. Side effects: cramping, diarrhea, gas, flatulence, irritation. Just long-term use, not good. Same teaching you're going to get from every single one. A common theme, you're going to hear it. Increase your fluid, 2 to 3 liters a day, high fiber foods, and exercise at that. This drug is magnesium hydroxide, which is milk of magnesia. It is a laxative salt, which draws water into the intestines by way of the salt, causing stool to swell and soften. It is usually pretty active. Within 6 to 12 hours, you'll see results, or in high doses, even 2 to 6 hours. It is given orally. The biggest thing is to need to increase as much fluid intake to avoid dehydration. Remember, if the salt is drawing water into the stool, it's taking it out of the rest of the cells, which is going to cause hydration into the body. The biggest contraindication is renal disease, and you have increased magnesium toxicity, so you have to be careful with that. And again, like all the other drugs, side effects: cramping, diarrhea, dehydration. The other biggest one for this one is the CNS toxicity with the renal disease that we need to be aware of and assess for with our patients. The osmotic laxative, or Miralax is what we know it as, retains water in the intestinal lumen, and it softens stools and also promotes bowel movements. Here, as you can see, it is given in a powder form, mixed in water, in about 4 to 8 ounces of water, and you usually can produce stools up to 1 to 12 hours afterwards. Now, you have to be careful with this because it does take effect pretty quick, and it's being used quite a bit for bowel preps for surgery or diagnostic procedures when they have to get colonoscopies or so people need to stay closer to the bathroom with these, as well as in removal of ingested poisons. Again, side effects: nausea, vomiting, bloating, gas, diarrhea, and cramping. Lactulose is a osmotic laxative. It is given to reduce high ammonia levels in patients with liver disease or cirrhosis. The common side effects include bloating, cramping, and diarrhea, like all the other ones. What it does is it breaks down into the liver the ammonia to urea, and it excretes it through the urine. In doing so, it is given orally or in an enema, and again, it can take effect within 1 to 3 days. In summary of all the laxatives, as you can see, a common theme. What did we say at the beginning? Laxatives and stimulants are for short-term use only. This is where people abuse it, and we have common disorders, eating disorders, or so from this reason. And if a constipation is there, it's hard, pellet-like feces. There are different stool frequencies. They vary depending on people. Some people have a bowel movement every day. Some people have it every 3 days. You need to know what's normal for your patient and act accordingly. But once they've established some type of consistent bowel habits and movement and what's normal for them, we would reduce the stimulants as much as possible because we do not need to be dependent on them. Remember, the key thing about this with our patients is we need to do diet and fluids and fiber and exercise before we give meds as much as possible because we cannot be dependent on meds. Now remember, caution with pregnancy and lactation because it can induce labor from dehydration and may be excreted also in breast milk. So you always need to cross-check that with your populations. Into this slide from the last one, remember I said we needed to double check to make sure. What do you check with your populations? Well, pregnancy or lactating, but at the same time you also need to check to see if there was any type of injuries for your patient, bowel perforations or avoiding MAG salts for renal disease causing the CNS toxicity. So you have to see what your patient's history is and background. And we also want to avoid the salt ones with heart disease that's going to cause fluid retention or any type of altered renal function that's going to cause any abnormalities such as dehydration of electrolytes. What is the opposite of constipation? Well, it's diarrhea. So, of course, we've got drug therapy for diarrhea as well, too. Our first anti-diarrhea drug is Lomotil or Imodium MD, as you can see. The key on this one is that it increases absorption of water into the small intestines, thus making more of a formed stool. But you need to be cautious with this in patients who have a fever, bloody stools, suspected infection like C. diff, or cardiac toxicity can occur with the misuse. The key on this one, if you notice, is atropine sulfate and Lomotil. The atropine is prescribed for medication to treat symptoms of low heart rate, bradycardia. And in doing so, we can overdose on this and cause another issue. It could cause high levels of the CNS, similar to like morphine, making us more unpleasant with the tachycardia, the mental state, the flushing, the overheatingness of our system, and blurred vision. We have to be cautious with this because if we treat this as an overdose for opiates or so, naloxone is also given in this. We also need to look at our interventions to monitor our diarrhea. We're going to check our fluid and electrolyte imbalances, but this drug can cause dizziness, drowsiness, and dry mouth. So we have to be careful when our patient is ambulating so they don't fall, and there's a fall risk on this medication. We also do this for, again, a short-term relief. We don't do these long terms. If our patient has the dry mouth, we can give them hard candy gum, little sips of water to help with some of that. And again, we're still going to be monitoring for any type of urinary retention. And we are just going to tell our patients when we educate them that they cannot mix it with any other CNS depressants or MAOIs and other mental behavioral health medications. Watch for operating heavy machinery because of the drowsiness and dizziness. Changing positions too fast can cause that and cause hypotension in that sense, and orthostatic hypotension. And then you want to encourage them to void every 4 hours and drink lots of water, but also to avoid caffeine. Again, this was another fun slide that the students put together to help you guys out. So an opiate anti-diarrhea, as you can see, you've got your cardiac issues, your dry mouth, you've got dehydration to make sure. And again, it's just talking about being lightheaded, urinating every 4 hours, no driving, and so forth. Just a different way of possibly learning about the drug and the side effects. When we talk about diarrhea, we also have to talk about drug therapy for irritable bowel syndrome. There's different types of IBS. There's IBS with constipation and IBS with diarrhea. So it would be IBS-C for constipation or IBS-D for diarrhea. Irritable bowel syndrome is a disorder characterized by cramping, abdominal pain, and either diarrhea, constipation, or a combination of both. Amitiza is used for IBS with constipation, particularly in adult women. It increases intestinal fluid secretion and improves peristalsis. It is treated for opiate-induced constipation, and it is given orally 2 times a day with food. The key is to give it with food and water to minimize the side effects of nausea. But if there is going to be continuous diarrhea, abdominal distension, or headaches, if that are persistent, then we need to report that to provider because those are some side effects that are unwanted for that. As you notice, it's contraindicated with patients with bowel obstructions or severe diarrhea. So you're not going to give this to patients, or you're going to be very cautious if you do, if they have ulcerative colitis, diverticulitis, Crohn's disease, or obstructions, because there's already issues with the intestines with the other diseases. So yes, these diseases, UC, diverticulitis, Crohn's, do cause diarrhea, but we have to be cautious of what the underlying problem is and if we're going to be making it worse or not. So leading us into inflammatory bowel disease, as you can see, Crohn's and ulcerative colitis, UC. These diseases which is inflamed in the intestinal tract. The ulcerative colitis is a chronic disease that causes inflammation and ulcers in the large intestines or colon, as you can see. Onset is gradual and worsens over time, but there can be periods of remission and it can last up to weeks or years. And then you got inflammation that's caused by autoimmune disorder or antibodies attacking their own tissues causing inflammation, and that's your Crohn's disease. It's a chronic disease that's commonly caused by inflammation of the small intestines, and it can also affect parts of the GI tract. Like ulcerative colitis, Crohn's worsens over time, but may have periods of remission. There are some drugs that can help to suppress that immune system and that prostaglandin response to decrease that inflammation. Sulfasalazine reduces inflammation in the intestines by inhibiting prostaglandin synthesis. The biggest thing here is that patients should take this medication with food and report any symptoms of fever, rash, sore throat, or fatigue, which can cause serious adverse effects. In addition to that, we need to make sure that if they're not tolerating it, if the nausea and vomiting, then we need to make sure that maybe we switch them to enteric-coated medication instead, which allows it to dissolve more into the intestines instead of the stomach, and this will help reduce the GI upset of the nausea and vomiting. And in addition to that, we need to make sure that we are checking our iron and antibiotics because they can affect the absorption of this. So if our patient is taking any of these other medications, we have to make sure that it's not taken together or contraindicated. And we need to monitor signs of infection like fever, white cell counts, skin rashes, in making sure to report any painful joints or fatigue or shortness of breath with this medication. Now, also note that sulfa is in the root word of this, so if they have a sulfa allergy, they cannot take this as well. And this is again one of those fun slides to help you probably learn more about the medication. As you can see, the fever, the nausea, the rash, the joint pains that they're talking about on that as well. So it does say caution with older people and with asthma. Remember I said shortness of breath. We have to make sure that they're okay with that. And you have to have renal and hepatic function very well. If you have kidney or liver problems, we need to be cautious with this drug. And another one, a different way for somebody as a group did this in a fun way to learn. Imurin, or a immunosuppressant, it suppresses the immune function of inhibiting B and T lymphocyte production. It has a slow onset of action. It may take several months to be effective. Nurses should monitor for infection and bone marrow suppression and liver toxicity. Because it's an immunosuppressant, it's going to cause high risk for infection and pancreatitis. We don't want to give with live vaccines because there's no immune system to fight it off, so we have to be very cautious with this. It is used as an off-label for irritable bowel disorder and dysfunction. It need to check our LFT, our liver functions, due to the high risk of hepatitis. We need to check our CBC and making sure that they have enough white cell counts and they're not neutropenic, which is low for being immune suppressant. Monitor for signs of infection and our temperature. Anything that you can think about. Remember, the B and the T cells help with immunity. HIV/AIDS have low T cell counts, so they're more risk of getting infected. Same idea with this drug. It's an immunosuppressant. It's decreasing those, so therefore our patient's going to have an increased risk of getting illnesses that have to deal with infections, live vaccines, so forth. We also want to teach our clients to lie down after taking this medication because nausea does occur quite frequently with that, and abdominal pain. And if the patient does get a little jaundice, then it needs to notify the provider as well. Some interactions that should not be given, it says allopurinol should not be given with this because it increases the levels of this drug. So if they have gout and they're on allopurinol, they cannot be taking this at the same time. It actually increases the effectiveness of this drug. It's too potent. We need to definitely make sure we're checking for those signs and symptoms of infection in our patients. We need to teach them to report any type of signs of infection: sore throat, fatigue, shortness of breath, dizziness, easily bruising, and so forth. It's just a continuation slide of one of the other students that they made, and as you can tell, if you do give it orally, it has to be given with food, and like I said, it does take a long time to take effect, and it can take up to 6 months. Now let's put it all together and see how we do. Now remember, when we're taking NCLEX questions or so, we need to discuss this when we're evaluating the medication effectiveness. Always focus on the attendant therapeutic outcome. For example, if it's looking at diarrhea, we want to decrease the diarrhea, or if it is dealing with constipation, what is the most effective way to take the medication, maybe a full glass of water or so. This first question, a client has received a dose of an as-needed medication, loperamide. The nurse evaluates the client after administration to determine if the client has relief of which sign and symptom. A, diarrhea, B, tarry stools, C, constipation, and D, abdominal pain. Let's focus on the subject. What is the drug? What is it intended to do? Were you right? Did you know that it's an anti-diarrhea medication? It's commonly used to administer after loose stools. It's for acute diarrhea, remember, not long-term use, not chronic, and also for things with inflammatory bowel disease. A client has been prescribed psyllium daily. What would the nurse administer with this medication to help promote its effectiveness? So we're looking at the subject. It's administration of psyllium. What's the note, the strategic word? Effectiveness, which means it's going to work really well. How do we get it to work? Think about what we need to do. A, give applesauce. B, a dose of antacid. C, 8 ounces of liquid. And D, a multivitamin of mineral supplement. If you picked C, giving 8 ounces of liquid, what is psyllium? It is Metamucil, the orange bulk forming laxative to help with constipation. So why do we give a full glass of water? It turns into like a jelly gelatinous solution, hard to drink as well. And what's the idea? It's pulling water into the stool in order to soften it and allow it to be excreted. So we need to make sure it's at least 8 ounces of liquid. It could be water or juice that we were talking about to help prevent the impaction of the medication into the stomach or the small intestines. Remember, it's gelatinous, it's thick after a while. If you've ever mixed Metamucil before in a cup, it's pretty thick and gross. So think about the more you dilute it, the easier it'll go down and the better the medication will work.